I think having directional atherectomy definitely changes lives. There's data supporting the use of directional atherectomy plus DCB to help improve the longevity of our work in endovascular therapies. So it definitely allows patients to have a better quality of life without having to return for repeat procedures and or repeat surgeries.
The results after I started using directional atherectomy are dramatically different than before. You can see that in, when I see patients post-op, when I talk to them about their symptoms, when we do imaging, whether that's ultrasound or CTA, it's truly night and day. It's dramatically different.
The outcomes that I have seen in my own practice and by following the long-term trials that are available in the literature has made me tilt towards using HawkOne more.
I've been very happy with the results that my patients have gotten from switching over from a rotational to a directional atherectomy device. I feel like it's actually increased the efficiency of my procedure.
I would say less than 10% of the time I actually use stents. And it's to the point where a lot of my patients ask me, like, why didn't you stent me? Isn't stenting supposed to be the best way? It's really like an old school way of thinking. And I really like to reserve stents for if I absolutely need it.
Directional atherectomy does achieve good lumen gain for us. And it's important to have decent lumen gain before you start performing drug-coated balloons, because we know that debulking, at least achieving less than 30% residual stenosis, will allow more of the drug that you're putting into the vessel to get absorbed into the adventitia.
As a surgeon, I feel directional atherectomy, where you actually cut the plaque or debulk the plaque, and you can also exteriorize it by packing it in the nose cone, makes me feel this is more closer to a surgical endarterectomy as compared to the other atherectomy devices which are available.
Before, I would use rotational atherectomy, and say if it was the pathology was isolated to one side or the other. I'm trying to make multiple passes. I'm trying to upsize my bits. I'm getting more aggressive just to get that luminal gain, right? I don't have to change anything with the HawkOne device. All I do is just rotate my cutter, and then that gives me the control to either prep the vessel or debulk the pathology that's there, and I don't have to change anything to increase my luminal gain.
I do think that HawkOne allows us to treat more difficult cases. I've done many cases where it's complete total occlusion, essentially from the ostium of the SFA to the popliteal artery.
It is a device I can use in a soft plaque, in a calcified vessel, in eccentric or focal lesions. It gives me availability to set it up from my operating room without a huge capital, and a similar device can be used in all of the patients that are required.
Perhaps one unique aspect of HawkOne is that because it's directional atherectomy, you can actually specifically target one side of the artery versus the other side. For example, if you have a common femoral artery lesion, you can specifically target the focal lesion itself without cutting into the contralateral aspect of the artery that might not necessarily have disease.
I'm not intervening on anything that I don't want to intervene on whenever I utilize HawkOne, because again, I'm in control. I have the direction of the atherectomy. I can take it right to where the pathology is and only treat the pathology, and then I'm done.
This device has such reliable results. If you have one or two passes, you pretty much know what you are going to see in that angio. But that's one of the things that I love about it, the consistent, reliable results that you can basically replicate over and over and over.